So let's talk about today respiratory distress syndrome, which is represented by RDS. It is also represented by RDS. It is also known as hyaline membrane disease. It is also known as hyaline membrane disease because the wax-like layer of hyaline membrane, it basically line the collapsed alveoli of lung. We will be discussing it later, but just remember RDS is also called as hyaline membrane disease. It is also known as surfactant deficiency disease because there is deficiency of surfactant in this disease. But how will we properly define the respiratory distress syndrome? So it is a serious lung disorder. It is a serious lung disorder caused by immaturity and inability to produce surfactant, resulting in hypoxia and acidosis. Now, how we can easily properly define the respiratory distress syndrome? So it is a serious lung disorder caused by immaturity. So the respiratory distress syndrome, it is the most commonly prematurity disorder, and in which there is inability to produce surfactant, meaning that there is deficiency of surfactant in this disease. Also, which lead to the hypoxia and acidosis. Hypoxia means decreased level of oxygen, and there is respiratory acidosis occur in this disease. As if there is a decreased level of oxygen, so it would lead to the glycolysis. It would lead to anaerobic glycolysis, which ultimately lead to the production of lactic acid. So that's it from the acidosis. So ultimately there will be hypoxia and respiratory acidosis. Now, before discussing the disease in detail, it's important that we should know about the surfactant. So let's talk about the surfactant. Now, inside an alveoli there are three types of cells are there. Inside an alveoli there are three types of cells are there. So what are three types of cells are present in the alveoli? That is, the first is that is called as type 1 alveolar cells. That is called as type 1 alveolar cells. Also there is type 2 alveolar cells are there. Type 2 alveolar cells are there, and there is type 3 alveolar cells. So how many types of cells are present in the alveoli? There are three types of cells which is found within the alveoli. That is type 1 alveolar cells. It is also known as type 1 pneumocyte cells, and it is predominantly it constitute as 95%, while the type 2 alveolar cells are type 2 pneumocytes. It contribute as 5%, and the type 3 alveolar cells, it is also known as type 3 pneumocytes. So the other name of alveolar cells are pneumocyte cells. Now, in type 1 alveolar cells, these cells actually it is lined by simple columnar epithelium. These cells they are lined by simple columnar epithelium. Simple squamous epithelium. Now, as you know that if there is simple squamous epithelium, so it will help in the gaseous action. So these cells, it will help in gaseous action. Secondly, if we talk about in type 2 alveolar cells, here these cells actually it is lined by cuboidal epithelium, and these cells it secrete a specific fluid, and that is called as surfactant. So surfactant is secreted by which type of cyst? That is type 2 alveolar cyst. Now in type 3 alveolar cyst, it consists of macrophagic cyst in the lung. So the macrophagic cyst in the lung, that is macrophagic cyst in lung is dust cell. That is dust cells. And which is the most important function of the dust cell? Actually, these are professional phagocytic cells, meaning it remove the microbes from the surface of respiratory. So the type 3 alveolar cells are macrophagic cells of the lungs, which is known as dust cells, and actually it helps in the removal of microbes from respiratory surface. Now let's talk about certain important points regarding surfactant. So what is the nature of surfactant? So basically surfactant is lipoprotein. Surfactant is lipoprotein. What does it mean? It means that it is the combination of proteins and phospholipids. So if we talk about the composition of lipoproteins, so I will be commenting that the surfactant will be the combination of proteins and phospholipids. But more truly speaking, the composition consists of 4 proteins and 10 phospholipids. So 4 proteins, 10 phospholipids, if they are combined together, they will form a structure of surfactant. Now, the second important point is that the surfactant, it is produced by type 2 lymphocytes. So it is produced by type 2 pneumocytes or type 2 alveolar cells. Now, it begins at 20 weeks. It begins in 20-week gestation period in the fetus, while the maximum formation of surfactant, it is usually in 28 week. While surfactant, it is more active in 34 weeks. The surfactant is more active in 34 weeks, and it is the duration of 28 to 34 weeks where the surfactant, it is present within the amniotic fluid, and that is the period of time when you are about to assessing the surfactant in amniotic fluid. So you can assess the surfactant in amniotic fluid by doing the amniocentesis. So amniocentesis, it is done between the 28 to 34 weeks, where we could assess the level of surfactant within the amniotic fluid. Now, what is the major function of surfactant? The major function of the most important function of surfactant is decrease surface tension. So it helps to decrease surface tension and increase the surface area. Why it is so? Just to prevent the lungs from collapse. To prevent the lungs from collapse. And the lung collapse is also known as atelactasis. So we can simply say that this surfactant, it helps in prevention of atelactasis. So what is the major function of surfactant? Just to decrease the surface tension and to increase the surface area to prevent the lung collapse. So just imagine, as in this disorder there is deficiency of surfactant. So if the level of surfactant is decreases, so what is the consequences of that? If the level of surfactant is decreases, so the surface tension will be increases and the surface area get decreases. As a result of that, if the surfactant level is low, so it would lead to a condition of atelactasis in the lung. So it would lead to a lung collapse. Now just imagine if there is delivery occur in female before the 34 weeks, so what would be the consequences in that condition. Is the respiratory distress syndrome, it is a prematurity disorder. So if delivery occur before 34 weeks, so in that condition the fetal lungs are not matured. So in that condition the fetal lungs are not matured. So what would we be doing in that circumstances? So in that cases we will be injecting the beta-methasone or dexamethasone in mother in the form of intramuscular or IM. So, and what it would be doing, it will helps in the lung maturation. So if delivery occur below the 34 weeks, in that case the fetal lungs are not matured, so for that we have to inject the beta-methasone or dexamethasone in the mother just to mature the fetal lungs. Now, what are the important risk factors regarding respiratory distress syndrome? So what are the important risk factors? So as we discussed earlier, the main risk factor is prematurity, and the second is gestational diabetes mellitus. That is gestational diabetes mellitus. So how actually in gestational diabetes mellitus, how actually the diseases occur? So let's say if there is a mother having diabetes, so what happens in that case? In that case, the blood glucose level is increased in maternal blood. So blood glucose level is increased in maternal blood. So the glucose, it crosses the placenta. Glucose crosses the placenta, and the mother produces the insulin, and there is insulin production started. As you know that what is the major function of insulin? Just to regulate the blood sugar level, but it is important that this insulin, it never crosses the placenta. The important point is that this insulin, it never crosses the placenta. So if it not cross the placenta, so what will be the circumstances? That the blood glucose level is increased in the fetus. So blood glucose level increase in fetus. Ultimately there will be insulin production started in the baby or fetus. If the insulin production is increased, so as you know that there is antagonist action of cortisol, so the cortisol level will be declined. So there will be decreased level of cortisol. Ultimately there will be the surfactant is not active in this case. So the surfactant is no more active. So if surfactant is not working properly, it means there will be increased surface tension and decreased surface area, which more lead to which lead to the most important lung feature, that is atelactasis. Also, if the surfactant is deficient, so it would lead to a condition of atelactasis. Also, there are certain necrosis occur in the hyaline membrane of the lung as well, which lead to the hyaline membrane disease. So actually this hyaline membrane disease is one of the complication of RDS. That's why we are also called this disease as hyaline membrane disease. So now let's discuss the clinical features of this disease. That actually how the patient will be presented to you if the patient is suffering from RDS. So the most important clinical feature is tachypnia. So there will be Tachypnia means increase respiratory rate, that is more than 60 beat per minute. So the most important sign is tachypnia. Also the second is, the main common sign is, that is nasal flaring. So in these patients, if you see these patients, so the nostril of this patient is wide, so there is widening of nostrils in these patients. So there will be tachypnia, there will be nasal flaring. Also there is expiratory grunting. What does it mean? Expiratory grunting means that the sound is produced by expiration. So when patient do expiration, and that time there will be sound produced, and that is called as expiratory grunting. Also there is chest wall retraction as well. So normally the chest wall, it is rises outside. Normally the chest wall rises outside, but what happens if there is negative pressure within the chest? At that condition, the external costal muscles, it draws inward. So as a result of that, the chest wall is retracted. So here there will be chest wall retraction, and the very most important sign is there is seesaw respiration. So seesaw respiration means normally in respiration the chest and abdomen, it rises simultaneously. But what happens in case of seesaw respiration? Let's say if this is a patient, now this is the chest of patient, and this is the abdomen of patient. So in this disease, what happens, that the chest of patient, it will draw inside or inward, while the abdomen of the patient, it rises upward. But normally the chest and the abdomen, it will rise simultaneously. But in case of seesaw respiration, the chest will be driving inward while the abdomen is driving outside. So that is called as seesaw respiration. So it is one of the most important signs of RDS. So also there is apnea as well. Apnea means there will be cessation of breathing. And there may be cyanosis, there may be pallor and hypothermia. Now, and if you check the cyanosis in this patient, so you will more focusing on nail bed of the patient. So cyanosis is more pronounced, it is checked mainly it is checked in the nail bed side. And also there is pallor and hypothermia. And why it is so? Because the decreased level of oxygen is leading to no oxidation, so ultimately there will be no ATP formation, which lead to decreased level of temperature, so there will be hypothermia in this case as well. Now one of the most important point is that if someone asks you what is the most important triad of respiratory distress syndrome, till now as we discussed a lot of signs and symptoms of a patient, so the most predominantly triad and important triad of RDS is, yes, that is tachypnia, expiratory grunting and chest wall retraction. So what is the triad of RDS? The triad of RDS is tachypnia, expiratory grunting and chest wall retraction. So this is the important triad of RDS. Now this is all about certain important features. Now let's discuss the diagnostic evaluation of the patient. How we will be diagnosing this case in a patient. Now let's talk about the diagnosis. So there are two conditions. If the condition is prior to birth or after birth. So if there is prior to birth case and death cases, what we will be doing, we will be assessing the surfactant level. So the presence of surfactant in amniotic fluid done by amniocentesis. As I told you earlier, that the surfactant level within the amniotic fluid, it is best assessing between the 28 to 34 weeks of gestation period. So if you are going to assess the amniotic fluid level, so you need to if you need to assess the level of surfactant, so you need to check the surfactant level within the amniotic fluid by a process that is called as amniocentesis. Also, if the case is prior to birth, so you can assess the level of lecithin and sphingomyelin ratio. You can take the ratio of lecithin to sphingomyelin. So if normally the lecithin ratio to the sphingomyelin ratio, it is 2:1. If the ratio is 2:1, it will indicate us that the fetal lungs is mature. But if the lecithin to sphingomyelin ratio, it is less than 2:1, it will indicate us that the fetal lungs is not mature. So if we talk about an RDS, if you assess the ratio of lecithin to sphingomyelin, so it will comes below the 2:1. So it is important. So in prior to birth, you are going to assess the surfactant level within the amniotic fluid by amniocentesis. Secondly, you will assessing the ratio of lecithin to sphingomyelin. And if the condition is after birth, so you can do the chest X-ray. The chest X-ray in this case, it is considered as a diagnostic. It is considered as diagnostic, and it will show the white patches and X-ray. So also you can do the ABG analysis as well. ABG analysis is important. ABG analysis is the confirmatory method. It is the confirmatory method for hypoxia. So arterial blood gases analysis is important as well. It is important, and it is considered as a confirmatory method for the hypoxia. As if there is decreased level of oxygen, so what happens that let's say this is carbon dioxide. So carbon dioxide, it is considered as the respiratory indicator. So as in the carbon dioxide, it is inversely proportional to the pH. So if there is decreased level of oxygen, it would lead to the increased level of carbon dioxide as well. So there might be respiratory acidosis as well. So there would be respiratory acidosis. So chest X-ray, the ABG analysis is important, and the most important is there is a specific test required in this condition, and that is called as shake test. This is called as shake test. It is also called as bubble test. Also, it is called as Clement test. Now, the shake test, bubble test, or Clement test, it is the most rapid method. It is the rapid. It helps in the rapid estimation of fetal lung maturity. So it helps in the rapid estimation of fetal lung maturity, and usually it is done in third trimester. It is done in third trimester, and in this test, what we will be doing? In this test, we will collect the amniotic fluid. Here we collect the amniotic fluid, and we mix the amniotic fluid with the 96% ethanol. We mix it with the 96% ethanol. Then we shake the mixture for 15 seconds. We will shake the mixture for 15 seconds, and after that we will be assessing the result after 15 minutes. So As a result of that, if there is bubbles appearance, so what it would indicate us, if there is bubbles and test tube, so it will indicate the maturity of the fetal lungs. If there is bubbles and test tube, it will indicate the fetal lung maturity. It will indicate the fetal lung maturity. But if there is no bubble and test tube, so it means that the fetal lungs is immature. I repeat, it is very important test. So that is shake test. And what is the significance of this test? It helps in the rapid estimation of fetal lung maturity. It is usually done in third trimester. And shake test, what happens that we collect the amniotic fluid and we mix it with the 96% ethanol and we shake the mixture for 15 seconds. After that, we will be assessing the result after 15 minutes. If there is bubble appearance within the test tube, it will indicate us that there is mature fetal lungs. But if there is no bubbles in test tube, it will indicate us that the fetal lungs is immature. So that's all about the diagnostic evaluation. Let's talk about the management of a disease. How we will be manage the patient. So let's discuss the treatment option. First of all, maintain the patency of airway. So let's discuss the treatment. First of all, maintain the patency of airway. Is airway, breathing and circulation. First of all, it is very important to assess. So maintain the patency of airway. After that, suctioning is important. First we will be doing suctioning on mouth, then we will be doing it on nose. But the point is that the suctioning must not be done prolonged in 15 seconds. So suctioning must be done within 15 seconds. Suctioning is not very reliable after 15 seconds. So always remember, if you want to do suctioning, so the maximum limit for the suctioning, that is 15 seconds. Now, first of all, maintain patency of airway. Suctioning is important. And give position to the baby. Position is very important. Give position to baby. And that position is called a sniffing position, or we can say rose position. In sniffing position, the neck is flexed with upper cervical extension. So sniffing position or rose position is given in RDS. Here the neck is flexed with upper cervical extension. Also we can give the oxygen as well. Oxygen administration is important. And also there is synthetic surfactant are there. Synthetic surfactant is available in the market. And that is Curosurf, Exosurf and Serventa. So the synthetic surfactant that is available in the market, that is in the form of Curosurf, Exosurf and Serventa. Also we can give the cortisol as well. So here we give the cortisol, or we can in the form of beta-methasone and dexamethasone. So we give the cortisol in the form of beta-methasone and dexamethasone. And the last treatment option is mechanical ventilation. So first of all, maintain the patency of airway, then suctioning is important. After that, giving position to the baby, that is sniffing position, then give the oxygen administration,